Hello, everybody. I like to welcome you all to coming to this webinar. Today, I'm pleased to present you some new, or for those of you that already know them, some products that will, I hope they will be of useful for you in your everyday life. And I hope that today's webinar will be profitable for all of you. I see that you are coming to this room, virtual room, and I will wait some minutes for allowing everybody to come in. Just to in the meantime, we wait for all our colleagues to come in. Please remember that you have the chat box where you can write down your questions, so I can have them at the end. I can read them at the end and try to answer as clearly as possible to all of your questions. So please don't be shy. Apply in the chat box so we can try to see together everything that was maybe not that clear during the process. Okay. Today I can see the participants. I see that you all come from several countries, so I guess by your name, of course. So I can see we have Asian, France, European, I guess also American one, or maybe some African friends. I can see them from Tunisia, for example. Some of them I know personally. So hello, my friends, everyone. And I think, yes, I see also from Philippines. Yesterday, 2 years ago, we had a little session. And so welcome to all of you. So, okay, I say we will start. It's 6 minutes past noon here in Italy. So today, what will be our main goal is to see a little bit what, accordingly to the flyer that you receive, the landing page that you receive, to see some useful products for you, I hope so, in the removable field. Since we are distributed all around the world, I take this occasion, first of all, to say hello to you, but also to thank all our distributors in every country, because without them, it would be almost impossible to be what we are. Today, Rainity Tree is proudly one of the leading company in this field, and one big part of this is done by our distributors. our commercial partners all around the world. So thank you to all of them. Let's go straight to the point. Today we will talk about OT Equator, our low profile attachment, and what I want you to remember always, that our website is a huge amount of information, videos, literature also, completely at your disposal. So wherever you are in the world, whatever the time zone you are, you have always available information and documents that you can download, video that you can see and share, because they are all on YouTube. So do never forget, sorry, that you have a huge amount of information, documents, videos, always available for you at your disposal. And all of them are collected in our website. So our OT Equator, our low profile attachment, that it's in my opinion, is very handy and useful device to treat overdentures. We will start a little bit from a kind of definition of overdenture. As you can see, according to Nertel, Ghisani, and Alia, an overdenture is a denture, of course, which is covering something else, namely attachments. Those attachments can be cemented into roots, like post attachments, or directly screwed into implants, so as direct attachments. What's the common basis? The head of this OT Equator. So you can have it for roots or for implants. Today we will focus a little bit more on implants, attachments, and this second definition, or actually what is the real goal of an overdenture, is to improve the patient quality life, basically, okay? And this by the attachments, of course. But pay attention, never misunderstand the real duty, the real meaning, the real function of a attachment. I mean, a denture should be always stable, regardless if there is an attachment or not below it. A denture should be always stable at first. Secondly, we can add some retention, and this is the real duty, this is the real function of a attachment. So too often I noticed that those two definitions, those two concepts are a little bit misunderstood and misinterpreted by even by people that work every day with overdentures. So remember always, a denture should be a removable denture, mostly should be stable at first, and secondly, we can add retention, and this is the duty, the real duty of an attachment. What I mean with this, an attachment is not intended to stabilize a denture. An attachment is intended to give retention to a denture. Why I stress over that concept? Because if you have an unstable denture, the attachment will fail in short time. So it's not because there is an attachment then that you reach stability. Okay, so if you provide retention to a stable denture, then your attachment, whatever it is, whatever its shape, will work at its best. Okay, so this is a very important thing to remember always. All the time we deal with removable dentures and attachments. I repeat, if you have any question for those who maybe are coming right now, please apply in the chat box so we can discuss. I can read your question at the end of my presentation, and I can reply you in a second moment. Okay. Okay, then what are the products Renity can offer you for give retention to a denture? We have three families of attachments. The first one is the first one that was born actually was the sphere, what you find on the right side of your screen. So the spheroline. Spheroline is a family of attachment composed by mainly by two attachments, the normal size and the micro size. All of them are available for any implant brand, any implant connection in the world, and all of them work with the same concept. So basically a female cap here in pink, of course, with different sizes and with different sizes, and a metal housing that will be embodied in the acrylic pink part of the denture. Okay, so please always remember to not to embody directly the female cap inside the denture. The best behavior, the best lifespan, working lifespan of the female cap is achieved only with a metal housing, only if it works with a metal housing. So always remember to reline the denture with a female cap plus its own metal housing. This is very, very important. You will see a better behavior of the plastic. You will see a last long, the retention will be more stable over the time, and it will last longer for a longer time. So the first attachments were the Sphero block, the Spheroline family in normal and micro size. After some decades, in 2007 roughly, we took the normal Sphero block and we decided to transform it in what is our big boy today. And with this, I mean the OT Equator that you find on the left side of your screen. You can see the OT Equator has a different shape. It's always an attachment, but this time it's a low profile attachment, okay? Again, the main idea behind our attachment is the same. So a female cap, again here in pink color, we have different colors for different retentions, and always a metal housing. So as said, in 2007, we took the Sphero block on the left side this time. And what we did, we increased the neck and we cut away all that was above its equator. Okay, so a sphere is like a globe, no? Like the planet Earth. We have a diameter, like all the spheres in the world. We took that diameter, we removed that everything that was on top of it, and we increased the neck. By increasing the neck, we had the possibility to put inside a thread. This thread is very useful for some other application that maybe will be the subject of other webinar that will follow this one. And this thread will provide us the possibility to use the OT Equator not only as a plain simple attachment, but also as a multi-unit abutment, okay, both for bars or for dentures, fixed retain dentures, like a conventional multi-unit. But it's not the topic of today. It is for sure the smallest attachment, direct attachment available on the market. Regardless of the retention and stability that it can offer, okay? And here you can appreciate the use of OT Equator in a chairside procedure. So here I thank Dr. Skrasha for this video, which is very, very instructive, very didactic. And this is our square screwdriver with a holder in a plastic that will keep the firmly attached the OT Equator on top of the screwdriver. With it, you go in your mouth, and once you know the implant brand and you know the cuff height, so the amount of gingiva, you can place your order, and you will get in short time your OT Equator. What's the next step? Once you tighten it into the implant, please remember always to respect the torque, given by the implant brand. You apply a silicone disc around the attachment and the female cap plus the metal housing. In the denture, of course, you need to have some free room, some free space to allow some drop of liquid resin to embody the metal housing. And once you proceed with some liquid resin, not too liquid, of course, it should be in its plastic moment. You go inside the mouth and you can control the excess of resin coming out from the lingual hole the doctor did, and you ask the patient to close the mouth. Once the resin is cured, you can check it thanks to the excess of resin in the lingual side. You are sure you can remove the denture, finish it with a bar, polished, and you can deliver it in a 10 minutes procedure. Okay, if you have everything ready, it will take you 10-15 minutes to activate the attachment. So again, is it just an attachment of the Equator? Let's see its main features. Actually, no, because I tell you it has an internal hole, and most important thing is threaded and also blind. This is a very important thing for the fixed denture when you use our OT Equator as a multi-unit abutment. It's available for from 0 sometimes millimeter, most commonly from 0.5 millimeter up to 7 for internal X implant, and from 2 millimeter to 7 for external X implants. There is a thin coating, which is a very welcoming surface for the gingiva. there are a ton of literature, and some of these, and the thin coating is there is a ton of literature about thin coating, and it's also available in the in our website. And last but not least, which is very important, it's available for all the implant connections. Okay, so for any implant you may have, for any implant connection you may have, we can produce a OT Equator. Just to show you why we have different starting points as minimum cuff height. For example, for the internal X, for the external X implants, the minimum cuff height is of 2 millimeters. Okay, because we need to cover the external X and we need to close on the maximum diameter of my implant. But let's see, in the internal X, okay, we can start from 0.5, so we can be lower, more aesthetics, mostly. And a question that we are often asked is if a switching platform is available with OT Equator. The answer is yes. The answer is yes, because it's not depending by the OT Equator, it is depending on the implant. So if the implant has a conical connection like the last one, and it's intended to have an abutment with the switching platform, as you can see, we can always have switching platform, just because we copy basically the connection and we do it compatible for the intended implant. Okay. How to manage the different cuff heights? You can have those two tools. Okay, it's a quite simple and I dare say also stupid tool, basically, because it's just, if you look on the right, it's just a platform and a pin. It's universal, this one, so it can be used on any implant, any connection, both conical, internal X standard, or external X, no problem. You can use on any implant. And how to read the color? Just you need to read the color exiting from the gingiva. The other tool has a ring that should be raised upwards and downwards, but basically once you touch the gingiva, the biggest ring touch the gingiva, you will have the same measurement. It's only two different ways to read the same measurement. Okay. And again, when I say it's available for implant, for any implant in the world, I mean any implant in the world. So the thing is, you don't need to change your implant just because you want to profit of the OT Equator. You can use the OT Equator on any implant. That means we fabricate it compatible for any implant. Okay, it's not one size fits all, of course. An implant has its own connection, and we are able to produce any connection in the world, even the unknown implant. Because I know that the implants are very huge number of compatibilities. So from an X-ray is not easy to to understand which implant is So how you can manage the implant, the recognition with Renit tree in this way. So do not send us X-rays, do not send us bad microimpression, do not send us drawings. Please don't do this. Send us instead those. Those are the best thing to understand what is the implant you are dealing with. Okay, I know that you can always send us the crown, the teeth, because otherwise the patient will remain without it. I know perfectly this. So you can send us microimpression, but please do a proper microimpression, okay? You should give us something like this, where I can see the thread and the connection. Sometimes the thread, we receive some micro impressions with no thread. Don't waste your time. If you cannot see the thread, and of course the connection, but the hardest part is the thread. If you cannot see a proper thread, don't waste your time and money. Don't send us the microimpression, okay? Redo your impression. Take your time. It's only a matter of 5 minutes and do your best, because otherwise we will not be able to produce anything on a partial impression. So do it properly. This is a picture I received from a doctor. Actually, the first picture I received was only of the pink microimpression, okay? The doctor sent me this picture, the pink one, within an improgum. And he asked me, hey, Claudio, does this, it's enough for you? And I say no. Why? Because the hexagon is completely distorted and I cannot clearly see what is the thread of the implant. And I say to the doctor, look, do something different, use another material, do it again, because the patient was still there with his mouth open. And I kindly asked the doctor to redo, just to redo simply the impression. After 5 minutes, 6 minutes, it sent me also the orange one. And now I say, okay, now it's good and we can proceed. Send me only the orange one. Okay. Okay, let's proceed with the upper part of the attachment. We have all, regardless of the connection, the retention cap and the head of the OT equator are always the same. So every OT equator work together with the female cap, and we just profit of the retentive area, the undercut area of the attachment with a elastic female cap. Okay, so the female cap is made of an elastic material that will just catch the neck of the OT equator and give retention. Remember that every color has a different retention. So no matter the metal housing you use on top of it, every color gives you a different retention, you can see. Here you can appreciate also that we have 3 different kinds of metal housing. One in stainless steel, the other one in pink is the same but in titanium. In the middle, you can see a very nice metal housing, which is called Smart Box. I will show you a case later on in which the doctor uses the smart box to correct more divergences compared to the standard metal housing. Let's have a look with our competitor. What are the main difference between us and our competitor? We made a complicated choice, actually. We decided to use different material for every cap, okay? This is more difficult to reach to achieve biocompatibility test, but we were aware that this will be a better road to follow because we could manage the retention by changing the material inside the cap. With our competitors did a different choice, strategic choice. He chose only one same retentive material, and by changing the internal diameter, it will give different retention forces. In our opinion, this is a risky road to follow because this may lead to some worn out of the sphere. It will worn out the diameter of the sphere, and the more you give retention to a cap by reducing the internal diameter, the more this cap will be aggressive over the titanium of the attachment. So more retention you give, more the cap is aggressive in terms of tightness over the attachment's head. So in our opinion, this is a risky road to follow. But also, talking about dimensions, you can see in the same mouth the difference in terms of dimensions. And here you can compare them. So here you can see on the right side, you see our competitor. In the left side, you can see the OT Equator. Our OT Equator will always have the same head. Okay, our competitor decided to produce two different geometries. The pink attachment was intended to have a more correction in terms of divergency. Okay. What we did a different choice to manage the angulation. We decided to produce the smart box. Also about metal housing, you can see the differences in terms of diameter. Both with the traditional, which is 4.5, or with the smart box, which is slightly bigger, 4.8, we still are smaller than the competitors' metal housings. And even, for example, on a gingiva level implant, you can see the differences. You can note that the implant at the same level has a completely different outcome in terms of attachment sizes. And in the mouth, the differences. Everything that I present to you today is backed up by some literature that we are proud to produce, and in cooperation mostly with the universities in Italy. We have a big cooperation with almost all the dental university, but not only dental, but also with the engineer university in Italy. And we do with their partnership some tests, some researches, which at the end are also published in reliable papers revised by third parties. So if you want to have a look, go in the in our website, in the literature section, and read them. They are available for download and you can read through them, okay? Let's have a look to some clinical cases. I will present to you today two cases, actually three, in which we have the doctor did a different choice in terms of implant placement and thus attachment positioning. Okay, the first case is the first picture where the doctor decided, accordingly to this classification did by Hertel and Kalk, in which they codify the the implant placement, also also taking into account the dimension of the implant and its superstructure and the relation with the implant bone loss. By doing this research, they try to define the most commonly places where an implant should be located. And the first case is the first picture where the implants are located roughly around the canine area. Okay. The second case has a four-implant positioning and follow more the second picture scheme. They also, in both cases, surgical cases, in surgical and prosthetic cases, they also theorize the one abutment, one time approach. That means they place the implant and they place immediately the attachment or the healing abutment, better, the healing abutment in the first moment, in the first surgical moment. So they didn't follow the two-stage with a covering screw, stitches, and then a reopening of the gingiva for the healing abutment. They just opened the flap, put the implant, and immediately after they put the healing abutment for the gingiva and stitches. Okay. Because they are convinced on what was found in this research of Abramson, that is a pretty old research in 1997, where they understood that every time you screw and unscrew the healing screw, because you are doing try-ins and blah blah, all the prosthetic step, the gingiva, they noted that the gingiva had an apical regression. So this was the basic idea for the one abutment, one time technique. So I will skip the main clinical step because I'm not a clinician. I'm not the best person to explain the clinical choices, but let's get through this case anyway. So the doctor placed two implants with an open flap, and as I said, he placed immediately the healing abutments and stitches. After the healing time of the hard tissue, namely the bone, and of course the soft tissue, they did a relining of the existing denture. This is an old denture of the patient. The patient was still comfortable with that. What they did a relining of the new situation in the mouth. And they, once the relining was made by the lab, the next step is just to understand the cuff heights, okay? The next step is to understand the cuff height of the for every implant we are dealing with, and what the doctor uses. He used the cuff height measurer. This time he used the one with the gold ring. Actually, if you note carefully, this gold ring has a kind of pre-visualizer for the sphere. In the main body, you can see there is a curve. That curve will pre-visualize you where the sphere will be. Okay, so it will help you to better understand if you have the correct height of the attachment. How the OT equator is tightened into the implant, you can choose between a contra-angle screwdriver. This screwdriver, together with a manual adapter here on the left, can also be used, of course, manually. And this screwdriver, it's compatible with the holder, this plastic device that will hold in place the OT equator. In case you want to proceed with the torque wrench and traditional screwdrivers, you can. You have two available screwdriver, one short and one long. Okay, and always in both ways. If you go with a contra-angle and the torque controller, or if you go with a torque wrench, a manual torque wrench, please always, and I repeat myself, always respect the torque, the prosthetic torque that the implant brands indicate. Okay, always follow the torque indication of the implant brand you are working with. Okay, this is very important. So after the height choice, the doctor inserted the OT equator, and here comes the smart box. So try to be smart in your life, use the smart box. No, I'm joking. Just to tell that the smart box is a double metal housing. It's made all in titanium, and the internal mechanism is a tilting mechanism, and it will receive the female cap. Remember, the OT equator female caps are always the same. So if you use them with a traditional metal housing, or like in this case with a smart box, you don't need to change the female cap. So that's the possibility of the smart box and how it's done. Again, it's just a double metal housing, one inside the other, with a fulcrum on the top, and that's the real movement that the smart box have. So as soon as the female cap touch the attachment's head, the tilting movement occur. So this will help to correct divergency up to 50 degrees, I mean 25 plus 25 with two implants. And also, this is an automatic movement, and also helps the patient not to destroy the female cap during the insertion, okay? So those are the female caps, and please note that we have a black cap at the bottom, which is not a laboratory cap as you may be used to, because generally black cap in rainy teaching world means a laboratory cap. This is the only exception. The black cap, the black smart box cap, is a positioning cap. It comes along the smart box. It comes already pre-inserted inside the smart box, and here you can see how to be used. So same story as before. You insert the OT equator, you tighten it accordingly to the implant torque value. A silicone ring to protect the gingiva, and the smart box as it is with the black cap, okay? Next step are always the same. Some free space inside the denture, some vent holes to allow the excess of raising to come out. Liquid or better plastic resin in its plastic moment between liquid and hard. Why I stress on that? Because if you apply to liquid resin, it will run all around and you may have trouble. So you need to wait for the correct moment for the curing resin. At this moment, you go inside the mouth and you can see the resin is still soft to exit the lingual holes. And once it has cured, you take out the denture and you see the smart box are embodied inside it. Please note the black caps, okay? The black cap is it's useful also to protect from the burr the smart box, because the smart box is it's very delicate mechanism, so it needs to be also protective from the burr. What is the next step? You need this tool. This tool, which is a universal tool, is made of 3 pieces basically: the handle, the central core, and the insertion tip. Okay, with this, you can insert the female cap inside the metal housing, but you also need to remove the female cap from the metal housing. And by rotating the main body and covering the other side, you have a extraction tip which is firmly glued. So the black tip is glued inside the central core, and just by rotating the main body, the handle, you can decide to use the correct side you need. So with a black tip, you remove the cap, like here, you remove the black cap, and now you can see the work of the black cap. You see that the black cap has kept away the resin from the smart box. Why this? Because if the curing resin enters the smart box, it will block everything. So you can see there is a little border where the liquid resin didn't get into the smart box. So now the smart box are free to move. With the insertion tip, you insert the female cap of your choice. And yes, now you can appreciate with this magnification, the mechanism which is free to move, okay? So, since we love our commercial partners all around the world, we try to give you, and since we love them and we do not want them to get crazy about understanding the correct OT equator you need, I want to give you some indication on how to place a correct order. You need to ask your local dealer that you want an OT equator with a smart box. You need to tell him or her the kind of implant and the implant diameter. Pay attention to the color of those 4 points. And last but not least, the cuff height you desire, okay? Those information will produce a code, okay? That the last one is the cuff height, And the first three number is the kind of set you are asking. 131 is OT Equator with Smartbox. Okay. Those four information are very important. So please, if you want, take out your phone and take a picture of this slide because it's very useful. You will not lose time. You will receive the correct piece and everything will be smooth. Okay. Second clinical case and prosthetic case. Again, same story as before, flap open, implant position with the healing abutments, okay? The doctor tried to respect as much as possible the sheen of Hertel and Kalk by placing four implants and stitches for the healing time. After 3-4 months, I don't know actually how many months pass for the healing. They did the same step as before. I will not repeat them. They investigate the correct cuff high and they placed an order for 4 OT equators. Of course, it's a good thing to check if there is a complete sitting of the abutment into the implant. It's always a good idea to check it. And after the on the OVD registration, this is the order placement for a traditional OT equator with no smart box. The point 2, 3, and 4 are always the same. If you don't need the smart box like in this case, where the implants are straight, you just need to ask your local dealer an OT equator with caps and standard housing. You see, the first three numbers has slightly changed. It's 130 this time. You have a 0 here, and the rest is the same. So the CAFI is the last number, and in between there is the implant identification, okay? Of course, for any platform, the yellow part will change, but it's our duty. It's not your thing to know it. You just need to communicate what kind of equator you want, kind of implant diameter, and the CAFI for information. In this case, in this clinical case, they didn't do a direct technique, so they need to take an impression, and your choice is between two kind of impression copings, and the laboratory analog is only one, which is this one. So they took the impression with the white impression copings. They place the analog inside before inserting them into the impression, and they produce the model. Okay, so those impression copings are it's one of the two options you can have. Again, since here the implants have no big divergence between them, they choose the standard metal housing. And you can see here, you have female cap plus metal housing, okay? In this case, there is no movement between the female cap and the metal housing because it's only metal to plastic device. And of course, the delivery, they did the check, and this is the final appearance. Sometimes you may have trouble, and sometimes you may find on your road some OT equators which are made of by some implant brands. since today I have an international audience, it is possible that in your country you have some of the Equator done by the implant brands themselves. Of course, we gave them the right to produce, but some of them has the yellow part on top, which is not only a welcoming surface, but it's only a surface that make the titanium very, very hard. So they are made basically in titanium, of course, but not with the nitration on top. In that case, the titanium is very soft and it will worn out in a short time. The result is your original female cap has no more retention over those Equator head. You have a solution. You have the undersized retentive caps. Okay, you have in two color, in color aqua and orange. Remember, the outer shape is exactly the same as the standard caps. So you do not need to change the stainless steel or the smart box or the anodized titanium inside the denture. So the metal box is always the same. You don't need to change it. You only change the female caps, which, like their names say, they are undersized in the internal diameter. Okay, so to give you retention even on worn out of the Equator. But what if you have a almost destroyed OT Equator? You have your last chance is to reconstruct with this ring the original shape of the OT Equator. Why this? Because there is not an abutment, an attachment that you can unscrew and change. This is a one-piece implant, so you cannot remove it from the mouth. So your second step in extreme cases is to regroove, to reshape, to recover the original dimension of the attachment. How you can do? By gluing this ring on top of the worn out sphere. Since you regroove, restore the original shape, do not use the undersized cap, use the standard again, use again the standard female caps. And what you can do, what else you can do, whatever you want, basically. There is no limit to your to what you can do. The only limit is your mind. The only limit are your idea. You can do removable RPD. So you can do removable dentures with attachments and clasp. You can do this. You can do conometric crowns and plus attachment. You can do it. It's your knowledge that tells you what you can do. But as soon as it can be designed, you can do it, okay? For example, in this last case, the dental tech had strong problems with the divergences. Okay, no smart box here will compensate the divergency he had, because look at this, check this out. Okay, those kind of divergency are unmanageable by the smart box. So since the tech was very smart, actually very skilled, what it did, it took the OT Equator for the normal, let's say, tilted implant, And since you have also the castable OT Equator available, what it did, it took the UCLA of the implant, cut the castable part accordingly to the insertion pattern, and here it comes. Here on the left, you can see a normally tilted implant, and over that, it took a direct titanium attachment, a direct OT Equator. Here and in the second implant here, it had extreme divergences. So it took the UCLA, it cut it accordingly, and placed in the palatal area with a mandrel the castable OT Equator. So here you can see the screwdriver. This tells you the implant angulation, okay? With a mandrel, it corrected the axis of the attachment, and with some wax, it started to produce a customized abutment. So what is the limit here? Only your mind. So if you think to do it and you can design it, so it's possible. Okay. Sorry, here I have an animation. And here you can see the UCLA, its screw, the OT Equator, castable OT Equator in red, and the metal box. You can see how much it's small and can be inserted into this prosthetic volume. In green, you can see a silicone mask of the denture. Okay, what the dental tech did here, the first thing he did was a denture with a teeth setup. Remember, as I said 2 days ago, a patient, remember always a patient do not need an attachment. The patient needs to chew and to smile, okay? So he needs a denture. So your first thought when you do something is to produce a denture, okay? After you define the denture this patient needs, you can start to think to the attachment to be inserted in that volume, okay? So don't be anxious when you receive an impression from a doctor and that says, oh, what kind of attachment we place here? Don't be in a rush. Define first the denture, the design of what actually the patient needs, and after you decide to produce an attachment. Look, Renity Tree will not be offended if you don't think at Renity Tree at first. It would be better to think first to the denture and then to choose the correct attachment. We will be more than happy of this, okay? I'm joking, of course. So that's the story. The tech did a 3 castable, customized abutments with the OT Equator on top in red, and 3 standard direct attachment, always OT Equator, okay? We cast the abutments, and that's the customized abutments in metal. So that's the story. After a perfect polishing of the abutment, please never, and I repeat, never polish the diameter of the attachment, because otherwise you will reduce with the polishing bars and whatever you use. Never touch the diameter of the attachment, never, okay? It must not be polished. So here you can see how the dental tech manage the extreme divergency on those three implants with three castable abutments of the equator. The rest is direct of the equator attachments, okay? And always remember the female cap plus the metal box. So, thank you. It was an honor for me to have all of you today. And if you agree, let's see a bit the question and answers. Okay, we had at the beginning some troubles with the sound and presentation. Okay, first question. Can we send a digital scan? This one, I guess, was at the moment of the impression, microimpression to detect the implant, the unknown implant. The thing is, the digital scan is not a reliable, in our opinion, so far for doing this kind of recognition. So because we need to have the actual piece in our hands. I explain why. Because too often we notice that digital scan are full of blood, saliva, and it's not a reliable scan so far, because it's too much related to the hands operator. Okay. And another important thing about the digital scan is that we need to see the thread, and we need to see all the details of the thread. With a digital scan, we cannot see under in the tip of the implant after the connection. So a digital scan, no, is not a good idea to send us. Second question, are all the components available in the Philippines? Yes, in the Philippines, we have our partner, it's a long time partner, which is called Fieldent. So Mr. Erwin and all his team will be more than happy to serve you, sir. I have not a name. It's called prosthodontics, but yes, the answer is yes. Fieldent is based in Manila. I will be there in a couple of months. By the way, we are organizing a tour and a session in Manila with its corporation. So you just have to apply to them, and they will be more than happy to serve you, sir. We have some troubles with the light today. Ben Ku is asking, any reduction in strength using the smart box? If you mean retention force, no. And if you mean that the smart box may break, I can tell you we did in 2016. This was a product launch in 2016. I personally followed not only me, of course, but I was one of the team that followed the research and plan design of this item. We tested it over 1,000 cycles And at the end of the test, the tolerances, the shape, and the sizes were still okay. And we tested it with a machine, of course, in a worst case scenario. So I mean, without saliva in dry environment. And the shape and the tolerances were still okay. So I don't know to what you are referring, but if you are thinking about a failure, I tell you no, and there is no problem. And if you, and I think you are pointing on that, if you are thinking on the retentiveness, it's a no again. The behavior, the performances of the female caps are the same. Thank you, Nadi. Also, thank you to you. So, any other question? If you have any, please apply. Thank you, HP1. Thank you. Thank you. Thank you, Benku. If you want to see something again from my presentation of today, just ask. I can jump back to the picture, to the slide, sorry, and say again something if you want to go more in deep. Thank you, River. Thank you. More than welcome. Thank you, Michael. Thank you. You're welcome, and nice to have you here. Welcome. Thank you, Yapnan. Thank you. Okay, Mr. Lewis asks, what, in your opinion, is the best way to capture the retainers, directly in the mouth or on a model? Well, that's an interesting question. As far as I can hear around, and I'm talking about conferences and lectures that I attend also as a listener, the main idea is that the direct technique is the best. With the direct technique, I mean to embody the female caps and the metal housing in the mouth, directly in the mouth, because you have not the in-between phases, and I mean impression and model production that carry an error. Anyway, you can try to manage as much as possible this micro error, but you will have always them. And I tell you something more. Some lecturers, also some doctors says, I prefer not to activate the attachment from the beginning. I mean, I have a new reline denture. I prefer to keep it as a total denture without attachments activation for 1 week, for example. So to go and investigate all the compressive spots, all the problems that may occur with the gingiva, I prefer to allow the denture to sit in a way inside the mouth. And after checking all those compression points and removing them, after 1 week, they prefer to activate the attachment. So it's up to you, basically. It's also a matter of time, possibility to do this directly in the mouth or not. Some patients are manageable, some other are not. So in my opinion, those lecturers are right. You should, let's say, activate the attachment after you check that the stability, again, concept of stability is fully achieved with the new denture. After that, you can activate the attachment, and the best technique, also in my opinion, makes sense, is to do it directly in the mouth. And I asked Melissa to ask me again, because I didn't understood which is what is her question. Please, can you apply again your question, dear Melissa? Excuse me. Thank you, Bimantara. Thank you for being here. Michaels, I would like to start using Equator for fixed bridges on implant. I have seen the video. I can learn more about this technique. Okay, Michaels. First thing to do. Okay, you already did actually. You had a look to the video, the information we provide. You can apply to the contacts you find in this slide that I kept. You can apply and ask for a fixed bridge session. So to go more in deep on that point. Another thing, dear Michael, go again in our website. You will see in the video area, you will also find all the webinars that we did during the lockdown, Corona, and blah, blah. You will find a huge amount of webinars where you can learn more about OT Bridge. The fixed bridges with our system is called OT Bridge. You can go there and see a ton of webinars, both by technicians, but I think mostly the most important are those from doctors. All those speakers are our opinion leader, and you can go there and have very high quality education, and it's already available for you. So you can go there and heard mostly not only one, but more than one speaker. So you will get everything as a first approach. Going in the webinar, I show you, I will share my screen. And I will go to the Renity tree. Renity tree. Just a second. I will switch in the English page, and I will share my screen. Okay, you should see my screen now. And if you go here in the video, I try to. Just a second. I reduce the yes. Okay, if you go in video and you go to video webinar, you have webinar in different languages sometimes. If you go webinar in English, of course, they are the majority. You can find, you see, OT Bridge. You just need to find OT Bridge here. This is 1. This is 2, 3. You have a lot of different webinars. So go in our web page, web page, you go to video and video webinar, okay? So there you can have a huge amount of things. You have also in different languages, Greek, Macedonian, whatever it is, okay? For example, Russia, you have in Russian language, you have in, we have some we did in Asia, for example. There is a wrong, no, here you are. So you have whatever you want, okay? You can go there and profit. Go back to the question. So Michael, I replied you. Thank you, Mr. Boone. Thank you, Mr. Chang. Again, Michael, what is minimum height above the implant we can construct at the equator fixed bridge? It is smaller than a conventional bar attachment to angle changing unit. Actually, the minimum height, if you are referring to the cuff height, you can have a very interesting thing with your T-bridge. You can hide actually your T-equator below the gingiva level. So in the removable, as today, I strongly suggest you to be above the gingiva level. But in the fixed OT-bridge solution for fixed dentures, you can be below the gingiva level, so you can hide the OT equator, because I agree with you, it is smaller than the conventional angled multi-unit. So you can have a better prosthetic teeth exiting from the gingiva. Thank you, Luis. See you next time. So Michael, so you come from Australia. Now I read your sentence. Nelly, Nelly, je me rappelle de toi, Nelly. Salut. See you, bye bye, Nelly. Thank you, Claudia. Some clients want video of different references. Nelly, again, you can go in the video and you can have everything. I will speak in French with Nelly. Alors, Nelly, tu peux aller dans le vidéo ici et après, tu vas chercher les vidéos de produits et les vidéos cliniques, vidéos webinaires. Donc, si tes clients te demandent de voir ça, tu peux leur conseiller d'aller dans les vidéos. Okay, I switch back in French. Nelly is a friend of mine in Tunisia. Thank you, Francis. Thank you. See you next time. Thank you, Sir Wang. Thank you. Or Mrs. I don't know, maybe. Sorry, I don't know if you're male or female. Thank you, Jason. Thank you. See you next time. And thank you, Anna. Thank you. Thank you for being here, and see you the next time. So if Melissa is still there, I still didn't forget she asked me something, but if she's still there, please re-ask me what you want. So, okay, if you have some more questions. Thank you, Susie. Thank you for being here. Thanks a lot. So if you have no more question, I will say hello to everyone. And again, if you want to have some other webinars, please apply to that contact and ask for some more, and ask also for the topic. Thank you, sir, which is, I think, writing in Chinese. I don't know. Oh, sorry, I cannot read Chinese. I hope it's Chinese. Maybe it can be also Japanese. I don't know. But thank you for being here from Asia. Thank you. It's nice to have you here. So I think we can end this session here. Thank you again for all of you, and see you the next time. Okay. Thank you. Bye bye. Bye everyone. Have a nice day and take care.